Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. This lecture will be also useful to all the fourth year students, interns, and person who are doing private practice. Today we'll be discussing on one of the very interesting topic, that is Kounis Syndrome, or we also call as allergic angina, etc. There are many other names for that. This is not rare, neither it is not very common, but it is not very uncommon also. You may see once in a while this type of a person presenting to you in your clinic. So we'll be discussing on Kounis syndrome. All the material what I have gathered is from different internets, that is YouTube's, Google, and other slidesheet.com, etc. So Kounis syndrome or we also called as hypersensitive acute coronary syndrome, allergic angina, allergic acute MI, or even microvascular angina. It is described as hypersensitive blow up inside the coronary arteries. So a person develops an hypersensitive response like anaphylactic reaction, and during that person gets involvement of the coronary artery, and that is labeled as Kounis syndrome. These are other alternative name, that is hypersensitive acute coronary syndrome, allergic angina, allergic MI, microvascular angina, etc. So one of the cause of MINOCA is microvascular angina, or we call Kounis syndrome. We'll be discussing under all these different headings, that is definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment, and complications. Hypersensitivity coronary disorders was described in 1991 by Kounis as acute coronary syndrome associated with allergic reaction. At that time it was also labeled as allergic angina, allergic MI, coronary hypersensitive response. Vasospastic changes seen in a Kounis syndrome does not always lead to infarct. May produce only angina or may lead to infarct. So it was described in 1991, and at present also you do see some of these cases. There was one paper published in 1950, 1951, 1991, 1998, 2008, 2012, etc. We are not going into detail regarding those parts. So now, what exactly, how you define Kounis syndrome? Kounis syndrome is an acute coronary syndrome associated with hypersensitivity or anaphylactic phenomena. Indirectly we say hypersensitive inflammation leading to acute coronary syndrome, not due to atherosclerosis. So Kounis syndrome or hypersensitive acute coronary syndrome, also labeled as allergic angina, allergic MI, and microvascular angina. So then came the another definition, that is Kounis syndrome is defined as an acute coronary syndrome, that is symptoms of chest pain relating to the reduced blood flow to the heart caused by allergic reaction or strong immune reaction either to a drug or to a substances. In 2013, a paper which was published on coronary hypersensitivity disorder, this Kounis syndrome was divided into three variants. Type 1 variants where coronary arteries were absolutely normal. Secondary to hypersensitive disorder, there was vasospastic allergic angina. So that was labeled as type 1 variant. And if there was already an atherosclerotic vessel and that plaque ruptures, or there is a thrombus formation due to allergic sensitive reaction, either anaphylactic shock toward drugs or substances, then it was labeled as type 2 variant, that is allergic myocardial infarction or allergic acute MI. And type 3 variant was already the stent which was put and there is a formation of thrombus in a stent due to hypersensitive disorders. So this was the three variants which were being described in paper which was published in 2013. So type 1 is anaphylactic reaction causing coronary artery spasm in a normal or near normal coronary artery and may progress to myocardial infarction. Type 2 was anaphylactic reaction combined with a pre-existing atheromatous plaque and results into acute MI. Type 3 was hypersensitive to intracoronary stent resulting in a severe stent thrombosis. So this was the three different varieties which were being described. So etiology is hypersensitive response to a different material like hornet stings, insect bites, or antigenic complex like polymers, scaffolds, drugs, drug-eluting stents, etc. Yes, there are some risk factors which are there, which will predispose more to Kounis syndrome like smoking, hypertension, hyperlipidemia and atherosclerosis. But atherosclerosis will usually result into type 2 variety of Kounis syndrome rather than type 1. There are conditions, drugs and environmental factors which can result into anaphylactic reaction or hypersensitive response like angioedema, bronchial asthma, exercise-induced anaphylaxis, food allergy, idiopathic anaphylaxis, serum sickness, urticaria, etc. These are different conditions. And there are a lot of drugs like antibiotics, analgesics, contrast media, glucocorticoids, NSAID, neoplastic drugs, dextran, heparin, protamine, streptokinase. There is a big list. And among environmental, ant stings, bee stings, wasp stings, jellyfish, grass cuttings, then poison ivy, latex. There are a lot of these things, shellfish, viper venom. All this material can result into anaphylaxis. So as far as the pathophysiology is concerned, it is a hypersensitive inflammation, and during that inflammation it also involves the coronary artery. Hence it is called as a hypersensitive coronary syndrome. So there is an concurrence of acute coronary syndrome with a condition associated with a mast cell activation involving interrelated interacting inflammatory cells including allergic and hypersensitive and including allergic and hypersensitivity and anaphylactic and anaphylactoid insults, and that was labeled as allergic MI or allergic angina. If we just go through little in more detail, during that hypersensitive inflammation due to either environmental factor or due to drugs or some conditions, there is a release of protease which is stimulated by mast cells. Protease released from stimulated mast cells during hypersensitivity that will activate the matrix metalloproteinase, which in turn will cause the breakdown of the fibrous capsule of atheroma. So this will be the variety of type 2 variety, and once that fibrous capsule is broken, the plaque makes the vulnerable to rupture and local thrombus formation leading to acute coronary syndrome. That is, even in a stent also, that will be similar phenomena which will be taking place. While in case of a type 1, it will produce coronary vasoconstriction. While here it is a plaque rupture, and in a case of a stent, it will produce thrombosis in the stent. So, lot of cells which takes a part. There is some trigger factors like insect venom, latex, drugs, contrast media, etc. Mast cells is activated, which will activate the lymphocytes and eosinophil. There will be release of mediators by granules from vesicles, etc., or even vesicle independent, and those will be histamine, 5-hydroxytryptamine, growth factor, TNF alpha, cytokines, platelet activating factors, etc. They will give rise to severe hypotension, hypoperfusion, and ischemia. This will have two mechanisms. One, local mechanism, where you will have a local effect on the coronary artery spasm, plaque erosion, and thrombus formation. While systemic effect will be what you get immediate hypersensitive response. Some will get a positive effects, and the person who gets an immediate hypersensitive response, we call that as an anaphylaxis. If there is a release of adrenaline, it will be a positive effect, and you will also have paradoxical effects leading to coronary artery spasm, plaque rupture, plaque erosion, and thrombus formation. This together we call as Kounis syndrome, either because of systemic effect or because of local effects. This is the mechanism which is taking role. We already discussed the three variants. This is little bit in more detail what exactly is happening in that pathophysiology. You can go through at your leisure time. Type 1 variant is in the normal coronary artery. Type 2 variant is already in a atheromatous coronary artery, and type 3 is in a stent. But basic is mast cell activation and then leading to the series of pathophysiological changes. So it is a hypersensitive. So basic is mast cells. Then you get an activation of macrophages and T cells. So macrophages, mast cells activates the macrophages, or macrophages activates the mast cells or T cells. This is all the things which is happening. Mast cells enhance the T cell activation. T cells can mediate the mast cell activation and proliferation. Macrophages will activate the mast cells will activate the macrophages. So it is a complex phenomena, and it is a vicious cycle of inflammatory cells. But basically the mast cell activation, macrophages and T cells. So vulnerable plaque, and then you go into an advanced lesion, formation of a thrombus formation. So this is a plaque erosion, plaque rupture, and then formation of a thrombus. Little bit in more detail. So there are a lot of mechanism which is playing a role. Coronary vasoconstriction, tissue factor expression, activation of platelets, intimal thickening, inflammatory cell modulation, activity of neutrophils, monocytes, eosinophil, etc., pro-inflammatory cytokines production, sensitization of nerve ending of coronary artery plaques, etc. These are all the different things which are happening, and these are all the different materials which are also playing a role, like protease, tryptase, kinase, then cathepsin D. We are not going into that detail. Leukotrienes, thromboxane, then platelet activating factors, etc. And you can see in this diagram, Kounis syndrome can result into a sudden cardiac death, and it will account for 3% of sudden cardiac death groups. But big group is hypertrophic cardiomyopathy, which is accounting for almost 36%. So hypertrophic cardiomyopathy accounts for a very big group. 36% is this, and indeterminate, that is another 8%. So indirectly it is almost accounting for 44% of sudden cardiac death. As far as clinical presentation is concerned, there will be two groups of symptoms. One group because of anaphylaxis and second group because of cardiovascular involvement. So symptoms like tachycardia, pre-syncope, hypotension, shock will be more of anaphylactic symptoms, while chest pain, bradycardia, orthostatic hypotension and cardiac arrest may be a symptoms because of Kounis syndrome, which is secondary due to anaphylaxis. It is quite common in adult, almost 46%. In children also it is quite common, up to 26%. So symptoms will vary from person to person depending upon at what stage the person is coming to you. Anaphylactic symptoms will be there, good number of those symptoms like weakness, malaise, nausea, vomiting, dysphagia, syncope, pruritus, urticaria, arterial hypotension, diaphoresis, paleness, palpitation, bradycardia or tachycardia. All those symptoms will be there very frequently because of anaphylaxis. In type 1, usually person will present with an anginal pain. In type 2 and type 3, person will come to you with an acute coronary syndromes with acute myocardial infarction. And because of that acute myocardial infarction, now you will see all those changes we call STEMI or non-STEMI. Or person may also present with cardiac arrhythmias in the form of tachycardia, bradycardia, QT prolongation, nodal rhythm, atrial fibrillation, ventricular ectopic, bigeminal rhythms, any one of those presentation which can be demonstrated by ECG. There is a big list between the hypersensitive myocarditis and Kounis syndrome. Symptoms, signs, ECG changes, laboratory picture, etc. Almost both are nearly similar. There are very minor difference. At your leisure time you can go through. This is type 1. We already mentioned that it is in a normal coronary artery. It produces coronary artery spasm. Hence it is also called as a microvascular angina, or it is also called as allergic angina. Type 2 is on a pre-existing atheromatous disease, plaque erosion, rupture and formation of a thrombus. So this is also called as an allergic acute MI or type 2 variety. If we compare these two, type 1 is always better than type 2 because prognosis is good in type 1, while prognosis in type 2 is relatively little risky. As far as investigation is concerned, history, clinical examination is absolutely necessary, and any person who is presenting with clinical symptoms of hypersensitive syndromes like anaphylaxis and he is coming to you with a chest pain, do not forget to examine the cardiovascular system and take ECG. As far as laboratory parameter is concerned, histamine, tryptase and troponin may be of use. ECG, if it shows you an ST elevation, it will be going in type 2 and type 3 more common as compared to type 1. Type 1 will be vasospastic variety. In that also you can get an ST elevation. As far as the laboratory parameter is concerned, total count will be elevated and there will be elevation of histamine level. An echocardiogram will differentiate the syndromes, which will be able to differentiate chest pain because of pericarditis or because of aortic dissection, etc. Coronary angiography will help to identify vasospasm or stent thrombosis or coronary artery occlusion. Very rarely we require a vascular biopsy to find out the mast cell infiltrations. Very, very rare. Newer technology which are called thallium scan or PET scan or SPECT scan, etc. will further helps to identify the coronary syndromes and rule out Kounis syndrome. This is an ECG which is showing you 1 millimeter of ST depression in lead 2, lead 3, AVF and V4 to V6, which suggests inferolateral valve myocardial ischemia, ST depression. And this will be more commonly seen in any condition which produces decreased blood flow to myocardium. And along with this, if person is having clinically symptom signs suggestive of an hypersensitive response, then it will fit with Kounis syndrome. So in a person with a hypersensitive response like anaphylaxis, if there is an ECG changes, do not forget to examine for Kounis syndrome. Sometimes the person can present to you with an atrial flutter fibrillation with ST segment changes. Here there is atrial fibrillation with ST elevation. Now always whenever a person is having ischemic changes in an ECG during anaphylaxis, always think in terms of Kounis syndrome. Here you can see the changes. You can clearly see the changes here. ST elevation. Here there is tachycardia, while here you can see now there is an ST elevation. In lead 1, AVL, while lead 2, lead 3, also there is a change. So whenever you get such changes, do not forget to look for Kounis syndrome. This is 13-year-old girl with fatal allergic reaction following a rubella vaccine. Now what is the management? As there is an anaphylaxis, the first drug of choice is glucocorticoid. Sodium chromoglycate is one of the drugs. H2 receptor blockers are also one of the drugs. Then anti-IgE and anti-interleukin 4 is also being utilized. So addition of leukotriene antagonist and immunosuppression may be also sometime life-saving. In type 1 variety, treated based on its clinical presentation, depending upon the severity of allergic reaction. First line of treatment is antihistaminic and glucocorticoids. If the person is having a severe anaphylaxis, adrenaline. If the person now presents with, along with that, coronary artery vasospasm, vasodilators like nitroglycerin, CCB, antihistaminic and mast cell stabilizer should be the other drug of choice in type 1 variety. In type 2, person with cardiac symptoms should be treated like acute coronary syndrome. In type 2 variety, Glucagon is better option than adrenaline for acute anaphylaxis with prior use of beta blocker. In addition to beta blocker, can increase the coronary artery spasm and ischemia. Opiate should be used with caution. So opiate is usually not used in type 2 variety. In type 3, acute coronary syndrome's protocol has to be utilized. Thrombus formation in a stent should be aspirated, and you can replace that by a new stent. Mast cell stabilizer is recommended along with steroid and antihistaminics. And particularly, if there is a histological examination shows eosinophil and mast cells, then you should take extra precautions. This is a big list of all the drugs which stabilizes the mast cells, like sodium nadochromyl, sodium chromoglycate. These are all the drugs which are going to stabilize the mast cells. So they can be the drug of choice during anaphylaxis. So in summary, treatment of type 1, treatment of allergic manifestation, plus coronary vasodilator like nitrate and calcium channel blocker. In type 2, treatment of anaphylaxis plus you will have to treat like an acute coronary syndrome. And in type 3 variety, you will have to replace the stent. You will have to remove the thrombus and remove the old stent and replace it by a new stent. So all these drugs will be very, very useful. Nitroglycerin, beta blockers, etc. are the drug of choice. Epinephrine is one of the drugs to be utilized in a severe anaphylaxis. Glucagon will be preferred over even adrenaline sometimes, over beta blocker also. Opiates should be avoided in type 3. So 3 varieties of Kounis syndrome. Type 1 is because of coronary artery spasm. Type 2 is a plaque rupture in presence of coronary atherosclerosis. And type 3 is a stent which undergoes a thrombus formation because of anaphylaxis. You should be able to recognize the condition, and then depending upon the severity, the drugs should be utilized and treatment should be mediated. And to reduce the amount of hypersensitive response, the use of mast cell stabilizers, antihistaminics, steroids, glucagon, etc. So as far as the stent is concerned, there are different choices which are being there. So you should use the stent which is having a minimal hypersensitive response, like nickel free, bioabsorbable stents, etc. Prognosis wise, prognosis is very good if diagnosed early and treated early. So thank you all for taking out time. I know that your time is valuable and I appreciate for spending some of the time with me. I request all of you, if you like this lecture, don't forget to press button like, give a thumbs up, and if you feel this topic will be helpful to your friends, you can share with your friends. Do not forget to subscribe so that I can upload the newer and newer CME lectures. If you got any suggestions, please do not forget to give your suggestions so that I can improve. All these video lectures are mainly for educative purpose, and I feel that this will be helpful to you in your private practice. Once in a while you might see this particular group of people. So see you in next lecture.